Hello, Miss Chetana. Are you there? Miss Chetana?
Ma'am?
Chetana, can you make me host?
Yeah. Okay, ma'am. I'll make you host.
Okay. Chetana, I need one doubt added. Chetana?
Ma'am? Yeah, ma'am.
When the speakers are sharing their slides, they need
Okay.
no?
Sorry?
When they
They
share
need...
slides, they have to be host, isn't it?
No, ma'am.
They can share without being host.
Yeah, ma'am.
Okay.
Okay.
Dr. Jarna is already here. Dr. Jarna, would you like to share your slide to see if it's working?
Sure, ma'am. Good evening, ma'am.
Good evening.
Is this visible, ma'am?
Yeah, it's visible. Perfect. That's great.
Yeah.
Okay, sure. Thank you.
Ma'am, I am making you host.
Okay,
Okay.
sure.
Okay.
Okay. Yeah, so you could stop sharing now, Dr. Jarna.
Yeah.
Okay, so that's great. We're ready. We usually try to wait for a few minutes because then the participants, just giving them a little time, because most people,
Sure.
OPD time for them. Usually it's practicing doctors who join.
Yes, ma'am.
Some scientists and some allied specialty people. So some of our physiotherapists are very interested in this as well. Some of the physical
Okay.
rehab doctors are interested as well. So, but basically anybody with interest in neuromuscular would be the ones joining in.
Right.
I have a feeling you'll have more. Sometimes we have more pediatric trained people, and sometimes we have more adult. Today's topic, you might get more adult trained people.
Yes.
Yeah. Although we do see a fair number of patients in children.
Right. The LGMD phenotype, yeah.
Yeah. Or the CMD overlap.
CMD overlap, right.
Yeah. Based on when the onset is. Lots of familiar faces. Dr. Vinita, nice to see you here. So Dr. Vinita is a physical medicine rehab person, specialist.
Hi, ma'am.
Hi. Dr. Jarna already tried hers. Sir has joined. Kadilkar sir, welcome, sir.
Good evening.
Good evening. Welcome, sir.
How are you? And
I'm fine, thank you, sir. How are you?
yeah, very well.
You're exactly on time. 2 minutes
Yeah.
earlier. We
2
have
minutes before, yeah.
we have many things to learn from you.
No.
Sir, I understand that we should be starting on time, but we generally tend to wait for a few minutes.
No problem.
Just a few minutes, because
No problem.
I think Dr. Jarna will tell you that it was only 6
Yeah.
now. Within the last few minutes, it's become 16. So people do join in.
No, we'll wait. There's absolutely no problem. I have finished the clinic, so
Okay, sure.
so it's easy.
Most of the people joining in are practicing clinicians. So for
Correct.
most of them, this is in the middle of the OPD, they participate.
Correct. Yeah, most
Somebody just
people
told
work late, yeah.
Yeah, so Dr. Vinita is our physical medicine and rehabilitation doctor. And Dr. Radhika works with us. We collaborate with her. We work in different hospitals, but we collaborate. She
Lovely.
is a neurophysiologist, I think Dr. Kushnama's friend. And
Lovely. Yeah.
yeah.
What's the name, say?
Dr. Radhika Manohar. Dr.
Oh,
Radhika,
yeah, of
say hi.
course, I know her. Yeah.
Yeah. So
Good evening, Radhika. How are you?
Good evening, sir. How are you?
Yeah, very well. Good to see you.
I'm looking forward to your talk.
Nothing much. Yeah.
No,
Sir, you have Dr. H.V. Srinivas here, sir. He's
Oh,
the
how
first,
nice.
yeah, he's the first neurologist from our state. So we are always very happy to have him. Sir, thank you
HVS,
so
sir,
much.
good evening.
Good evening, Satish. Good evening.
How are you, sir?
Very fine, thank
Very
you.
good to see you.
Yeah. All because of Anne.
No, sir, it's
Really,
very
really,
encouraging
she's
being there.
got a fantastic group
Yeah,
together. Yeah,
Sir is always encouraging us with with his presence and telling us to do better.
really.
Yeah. Dr. Vinita said she put an alarm clock so that she's not missing your talk. So she's joining in on time. Sir,
Yep.
HV sir, do you want to introduce him? No. Okay. So I think we're just exactly 8:30.
Yeah.
So just a few minutes. There's some fairly senior people around, Dr. Vaibhav and
Yeah.
people. I'll
Just give me a minute. I'll
Would you like
kindly.
to share your slide to see if it works? Jarna's already done it.
Yeah, I'm getting the slides together. Just give me half.
Sure, sure, sure.
Yeah, can you see them?
Slides are perfectly visible.
Right.
You go on to slideshow mode to check.
Yeah.
Yeah. Yeah. Animation is working. Everything's fine.
Great.
So shall I take a few, maybe, I think there's enough people. I'll just take a few minutes to acknowledge some people and their
Yeah,
contribution.
of course, of course. I think Jarna goes first. How do we do? Yeah.
I think that's that.
Yeah, that's the
suggest,
plan.
sir. Yeah,
Right.
sure. We'll go by what you suggest.
Yeah, no, whatever is your regular plan.
We usually allow you are the ones that are hosting the
No,
meeting
I think
according to your convenience.
yeah, let Jarna go first and then I'll
Sure.
follow.
Sure. So thank you to Organization for Rare Diseases India, which tries to do the maximum amount of work that they can do for encouraging new parent support, for advocacy and spreading knowledge and awareness, as well as supporting patients with various rare diseases. It's thanks to them that we've been able to do this work, and they have been. This is our 34th session. So big thank you to ORDI for doing this. And big thank you, Dr. Khadulkar sir. It's an honor having you here. Thank you so much for agreeing to do this.
It's my pleasure.
No, thank you so much. And thank you to all the super audience. As I can say, most of these people are people I really look up to, from everyone to Dr. HVS to Dr. Radhika to lots of the people around here. And thank you, Dr. Jarna. It's good to see young people interested in neuromuscular. We'll see more people enthused by it. So we are just a few minutes short. So if you could slowly start, sir, maybe slowly, Dr. Jarna, allowing those who keeping in mind that those who come on time so that they're not missing out. Thank you.
So I start by sharing the screen.
Yes,
Yep,
please.
please.
बढ़ ही रहा है 1 मिनट का, तो 1 मिनट 30% थी।
Is my slide visible?
It's nicely visible. Thank you, Dr. Jarna.
Yeah. So I'm Dr. Good evening, everyone. I'm Dr. Jarna Mahajan, and I am a DM neurology. I've finished my DM neurology, and I'm a consultant neurologist at Bombay Hospital. And first of all, I would like to thank all the organizers and Khadilkar sir to give me this opportunity. Today's discussion is one of the most excited topics for a neuromuscular enthusiast. That is a genotype-phenotype correlation. So it's a fundamental concept in genetics that explores the relationship between the genetic makeup, which is the genotype, and its observable traits, which is the phenotype. Well, the importance is obviously to understand how specific genetic mutations or variations influence the physical characteristics and thus helping us in diagnosis. It also helps us in predicting the progression and also to target therapies. But it has its own perks, it has its own limitations. And through my presentation, and after my presentation, in fact, Dr. Khalilkar sir will also speak about this. So we'll talk about the limitations of genotype, phenotype, and its correlations. So I would like to start with the first case, which is the story of siblings. This 15-year-old boy came to us with upsquatting difficulty from the onset of 3 years. He had difficulty to run and he also had fatigability. His CPK was 450, and as we can see, the RNST is showing significant decremental response, suggesting of postsynaptic neuromuscular transmission defect. He was started on pyridostigmine and he showed a significant improvement. Unfortunately, we don't have the pre-video, the pre-treatment video. So this is the post-treatment video where he's completely able to do the upsquat very easily. So he got cured into the inverted commas. Within 3 years, the same family came to us with their daughter, his sister, 12-year-old girl with upsquatting difficulty since last 2 years and difficulty in climbing stairs. She didn't have any fatigability, but her CPK was 1830. As we can see in this video, she has significant difficulty in getting up. There's a truncal weakness also, and there is an exaggerated lumbar lordosis with some waddle while she's walking. Her EMG showed small motor unit potentials, which was suggestive of myopathic units. And also, she also had postsynaptic neuromuscular transmission defect in the form of decremental response on RNST. So we did the genetic study and we found that they both had GMPPB mutation. Now we know that GMPPB mutation is like the bridge between the neuromuscular junction defects and also the limb girdle muscular dystrophy. So the story of these siblings tell us the intrafamilial variability. And it also gives the lesson that genotype alone cannot predict the phenotype. In fact, it also has an impact on prognosis, counseling, and management strategies. Coming to the next two cases, the next two cases are phenotype trap. So usually use this word that stressing too much on phenotype is a phenotype trap. We'll see with these two cases. 30-year-old male with history of gripping difficulty. As we can see in this photograph, he also had wasting of FDIO. He had a history of foot drop, and the EMG was suggestive of myopathic units in upper and lower limbs. Before I come to the differential diagnosis of the first case, let's see the another case with similar findings. 26-year-old male, born of non-consanguineous marriage, symptomatic since 3 to 4 years, difficulty in climbing stairs up, followed by he noticed difficulty in holding pen with left hand and lifting heavy weights. And on examination, he had this significant scapular winging. As we can see, the medial border is quite prominent. So if you ask me differential diagnosis based on the phenotype in the first case that I showed, it looked more like neurogenic, localizing to anterior horn and maybe GNE because he had foot drop and FDIO weakness. Case 3 looks like myogenic, but because of the scapular winging, I would lean towards calpainopathy or maybe congenital myasthenic syndrome. Well, the report was GNE for the second patient. He had two variants on exon 12 and 3. Both were heterozygous. One was likely pathogenic and one was with variant of uncertain significance. So in this, we can learn that phenotype alone is not enough for the diagnosis, and it should be correlated with the genetic test. Finally, my last case will be to show that one gene can have many phenotypes. As we can see, the titin myopathy, this is a very large protein, the titin, and it can present with different phenotypes ranging from neonatal age presentation with hypotonia, dysmorphic facial features, early cardiac involvement, followed by adult onset distal myopathy. As we can see in this patient, he has a subtle foot drop and distal weakness in upper limb. And then there is an adult onset LGMD presentation. So to conclude, my main aim was to show the limitation of genotype alone, limitation of phenotype alone, and they should always be correlated with this concept of genotype-phenotype correlation, which I think Sir will take into the depths. Thank you.
Thank you, Dr. Jarna, for elegantly introducing the topic so well with such beautiful examples. Before we, I'm taking the liberty, okay, allow. Okay, I'm taking the liberty to
I'll
present.
stop sharing, ma'am.
Yes, please.
Yeah.
See this. So, Dr. Kharalkar does not require any introduction in this forum. That is evidenced by the numbers of people who are attending and who have joined on time. So, sir has inspired many people in the neuromuscular world, and currently is the dean of medical faculty and professor and head of department of neurology in Mopey Hospital. And sir is known to have taught generations of people interested in neuromuscular world and authored many books and over 250 publications, and been granted the Best Teacher Award and GMC and JJH. Sir, without much ado, welcome to you, sir. Please take over.
Good evening, everyone. And Anne, thanks very much, firstly, for organizing this program, and secondly, for asking me to be here. It's a fantastic forum, and I'm sure all the attendees will enjoy the discussions every time. So my topic today is, oops, just give me half a minute. I brought out the wrong one, I think.
Sure, we're on time. We're bang on time.
Yeah.
So we have time.
Yeah, that's the correct one. Oops. Right. So what I thought I would do is to give a commentary on the clinical and genetic approaches. And Dr. Jarna has introduced the topic with the 4 cases where the genotype and phenotype mismatch, if you like, was there. So let's first start with the clinical approach, the phenotype, or if you like, the phenotypes. So basically, when we're looking at a phenotype, we go over these questions. When has the disease started? How long has it been going on? How is it evolving? What has it affected? Which is the phenotype? What has it affected? Who else is affected? And which diseases are common in the area where the person is practicing? I think that's our clinical approach. And the last one is actually very important because different diseases are manifesting with different frequencies in different parts of the world. So where you are practicing, what exists is so important to know. But what has the disease affected is really the phenotype, which is the point of discussion today. So how does Oxford Dictionary define a phenotype? It's a set of observable characteristics of an individual resulting from the interaction of genotype with the environment. And the environment includes milieu interior and milieu exterior. So the definition of the phenotype, if you look at it closely, is the set of characteristics that come out, but it is a result of genotype with the remaining milieu interior and the milieu exterior. So obviously, the phenotypes will be different from what the genotype intended it to be. When we are analyzing the phenotype, we take this zebra stripe approach or the pattern recognition approach, where we sort of look at telltale features of that particular affectation and say, okay, this is there, and therefore the stripes are there, therefore it must be a zebra. But the pattern recognition approach of a phenotype can be a little complex. When all of us see this picture, the glasses and the part of the head, we think that it's going to be Mahatma Gandhi. How do we know it? Pattern recognition. By seeing this much, we infer that it will probably be a picture of Mahatma Gandhi. But within the lower motor neuron, the muscles, myoneural junction, peripheral nerves, roots, anterior horn cells, we separate them for the purpose of our understanding and for the purpose of a kind of clarity that it gives. But in life, they're all working together, and therefore you can see a lot of admixtures of the phenotypic presentations. In this slide shows you the broad ones, like muscles are symmetrical, hypertrophy is common, they're proximal, and so on and so forth. So based on these, we would recognize patterns and therefore think that if these, we infer that the disease may be like anterior horn cell or muscle or myoneural junction. But in some places, what look like Mahatma Gandhi may actually be the common man of R.K. Lakshman. The phenotype may not necessarily mean what we think it to be. So within a pattern, or a zebra stripe pattern, if you like, there are spectra of a variety of situations. We go by the most common ones, but then the uncommon and the rare ones exist. So it's very important to recognize that the phenotype by itself is not sine qua non with a molecular diagnosis or a disease entity, but commonly it is of certain and uncommonly of certain others. And a classic example for this I can quote is neuralgic amyotrophy. If you see the center of the circle, the most common classic phenotype, upper plexus, monophasic pain followed by weakness, is the core of the syndrome of neuralgic amyotrophy. But as you go to the outer circles, you see how diffuse it becomes. Recurrent presentations, painless presentations, extended phenotype, lumbosacral phenotype, long thoracic nerve, phrenic nerve, posterior interosseous nerve, anterior interosseous nerve, distal phenotype. So what we call zebra stripe is the core. But around that, there are so many uncommon presentations of a particular phenotype. So that's important to recognize. So why do we study the phenotype? An experienced clinician can arrive at a succinct differential diagnosis so that the investigations needed are few and the therapies can be rapidly used. So phenotype you use as a lead to where you're going. And then you take help of electrophysiology, CPK, muscle histology, muscle MRI, genetic studies to come to a complete diagnosis. Now, with this little preamble about the phenotype, let's look at the limitations of the phenotype approach. See, most clinicians are taught that clinical neurology or clinical medicine is supreme, and you should be able to achieve a lot just by looking at the clinical features or the phenotypic features. But there are limitations to this approach. One limitation is one phenotype and many genotypes. The example I'll give here is the Duchenne muscular dystrophy phenotype, where a young boy, lordosis, calf hypertrophy, ankle contractures, and massive CK elevation, you know that this particular situation will be due to a particular disease which arises from XP21 myopathy and the dystrophin protein problem. This figure that I have shown here, I actually like this figure because it shows the ankle contractures, it shows the large calves, it shows the gluteal hypertrophy, it shows the lordosis, also shows the brachioradialis hypertrophy. So it really shows lots of things that you see in Duchenne muscular dystrophy. And in this particular boy, there was a mutation in the dystrophin gene. But we know that even though commonly the gene at fault will be the dystrophin gene, this phenotype can be a result of a variety of genotypes, and they can range over limb-girdle muscular dystrophy, congenital muscular dystrophy, sometimes Pompe disease, and at other times spinomuscular atrophy. So one phenotype can be a result of many genotypes, which is an inherent fallacy in studying the phenotype and imagining a genotype. So to show that, I'll show you one case. Calf hypertrophy, mild proximal weakness, mild water, severe weakness and hip abduction sign. See, this girl has large calves, very muscular. And if it was a boy, you would think that it is a Duchenne muscular dystrophy. But see the way she gets up in the Gowers sign. See, that's the hip abduction sign, which suggests that the hip AD ductors are weaker and hip AB ductors are stronger. She'll get up again. See that? So this particular girl had a sarcoglycanopathy. So one phenotype, many genotypes. Limitation 2 is some phenotypes are nondescript and they cannot suggest a genetic diagnosis. That's the second limitation. Example is limb-girdle muscular dystrophy. In our collection, I think about 40% of patients, we can get an inclination as to what the gene will be. And in remaining 60%, it does not tell you a particular diagnosis. Also, the populations being studied are different in the different parts, and therefore the genotypes vary according to the regions and the population that's being studied in that given situation. So this was a paper that we wrote in making sense of clinical spectrum of limb-girdle muscular dystrophy. It's a very nice paper and makes you feel that in a lot of patients, you can, looking at the phenotype, you can talk about what genotype you'll find. But when we actually take the ground reality, it's a little over 40% in my practice of limb-girdle muscular dystrophy. So even though in limb-girdle muscular dystrophies, there are these phenotypic clues, all of them are valuable, but you will see them only 1 in 2 patients. Right. The third limitation is that the phenotype may actually lead you up the garden path and may suggest an incorrect diagnosis. And this happens from time to time. This 19-year-old male presented with distal weakness, foot drop with contractures and proximal weakness. Oops, something wrong with this slide. God, I don't know what's wrong here. Okay, I'll go to case 2. I hope this shows. No. Let's forget the slides, but I'll tell you what the cases were. There was a young boy with large calves, and he was sent to me as probably Becker muscular dystrophy. But on examination, he had a wasted EDB and he had little tremors of the hands, and he actually had a spinomuscular atrophy. So that's the third limitation, that the phenotype may actually take you up a wrong genetic diagnosis. Fourth limitation is difficulty in localization. Now, we all learn this table from the time we enter neurology. Muscle versus anterior horn cell, the two motor conditions that you need to differentiate from each other. And if you see all the points written on this table, none of them is absolute. You know that anterior horn cell diseases can be symmetrical. You know that muscle diseases may be asymmetrical. You know that anterior horn cell disease can be proximal. You know that muscle disease can be proximal and distal. So if you look at this table, it is 6 of one and half a dozen of the other. And therefore, there are no hard points for localization between these two common conditions, common localizations, muscle and the anterior horn cell. This is the boy whom I was talking about. 23-year-old, up squat difficulty, can't run well, large calves, sent as Becker muscular dystrophy, but had a wasted EDB, wasted hands, and tremors of the hands. So these were the clinical features that told me that what is looking like Becker is actually a spinomuscular atrophy, which it turned out to be. And he had a SMN7 deleted spinomuscular atrophy. So the lessons we learned from this case are large calves can be seen in neurogenic conditions, and some SMAs actually look like Becker or Duchenne. And tremors of hands very often point to neurogenic problems. Now, this is something that I have often used in teaching, that if you see tremors, it will be neurogenic. Most of the times you're likely to be correct. But look at this patient. His whole family has a myopathy and these tremors due to MYBPC1 gene. So the point I'm driving at is, in the phenotypic presentations, though it can give you a lead to where you're going, sometimes even there is difficulty in anatomical localization. If you saw a tremor like this, it will be very hard to believe that you're dealing with a myopathy. Of course, it very rarely happens. In all these 3-4 decades, I've seen only 6 or 7 patients with myopathy who have tremors. Right. Another example, this 26-year-old man presented with wasting of the FDI and a foot drop. Look at how wasted the hand is. If you see a hand like that, you will think of cervical spondylosis, motor neuron disease, things like that. But the man has a foot drop. And his tendon reflexes are normal. And he turned out to have a GNE myopathy. So myopathies can be distal, myopathies can have profound wasting. So both the points going against that table. So that's the fourth limitation, that even in anatomical localization, particularly between anterior horn cell and muscle, it may not be easy based only on the phenotype to reach a diagnosis. The fifth limitation that I'm going to discuss is phenotype changes over time. This is again a very important concept. Now, this is a boy whom I saw very early, I think at the age of 4 years or so, with CK elevation. Now, a young boy with only CK elevation, you would think of a Duchenne muscular dystrophy. So we looked at him. We thought it was Duchenne muscular dystrophy. We did the DMD gene, which was normal. At that particular time, we did not have access to the whole genome or whole exome, and we left it at that.
Hello, sir. Did we lose you for a minute? Uh, Hello, Dr. Katalkar, are you there? Hello, Dr. Vaibhav. Presentation got stuck. I'll just try and get hold of him to see if we can help with that. It might be a network issue. Dr. Jharna, are you there? Dr. Jharna, are you around? Dr. Vaibhav, I'm trying to get through to Dr. Kadalkar. Dr. Jharna, are you both in the same location or are you in different places? Dr. Jharna? While we are waiting for sir to come back,
Ma'am, excuse me, ma'am. Hello? Hello?
I was just on the phone with Dr. Kadalkar, Dr. Jharna. He said he lost the connection.
Yeah. He's just joining back.
Okay. While he's joining back, are there any comments or anything? Because I see a lot of very senior clinicians and surgeons who deal with the complications of LGMD and CMD being present in this forum. Everyone to Professor Sureka Raja Diksha, to people from literally people from Kashmir to down very south. Would anybody want to discuss anything? And some scientists as well? And some people from overseas as well, pediatric neurologists from overseas. Anybody wants to discuss anything while he joins in? It's a connectivity issue. Anybody wants to join in with any of their experiences with the level of confusion or the overlay between phenotypic presentations between various LGMDs? Anybody wants to
Can
come?
I share something, madam?
Yeah, please do. Please do.
And the sir has given a beautiful tip today that the tremor is an indicator of neuropathy.
Uh-huh.
So that was a good thing, but I think the problem is in two phases. The first thing is to localize to muscle disease, and so there was some cases confusing SMA. I personally find that that absence of reflexes and this electromyography can be really helpful. We had a very confusing case like that only. But the moment we put the needle in, we were very clear that this is a neurogenic and this is an SMA. So before sending genetic tests, EMG can be, you should do a EMG first.
Yeah.
So once you get neurogenic pattern, you can say, because the problem with SMA is that SMA is a different genetic test. So that is
Yeah.
also a problem. So EMG can really be helpful. That's the only thing I wanted to add.
That's a great thing to add in. And thank you, Dr. Vaibhav, for adding that in. But from a pediatric perspective, one of the things that we do which make our adult neurology colleagues dislike us intensely is that we are very bad with localization. One of the reasons is that if we put a needle into a child, often the child is screaming and things. And sometimes with the milder phenotypes,
Madam, AMG, you just have to see it's a myopathic or neurogenic, so it doesn't matter. Even the child is crying. If
no,
in
it's
fact he
not that.
cries and contacts you easier, I think.
No, I understand. But sometimes the genetic test is cheaper than the EMG.
No, but the SMA genetic test is different. The
Also,
LGMD genetic
no,
test is different. It won't show
no,
up in BEST.
no.
So
SMA
once you
genetic
put
test
the
is so much cheaper.
so once you put the needle, you will get neurogenic. You can straight away send first for
Absolutely.
SMA.
Absolutely. But
So you just have to see the MUPs. So we don't have to see in the rest at all. So
that
EMG can
you're
be
absolutely
really
right, sir.
helpful.
But you're seeing older people. When I'm saying when we are seeing younger children, well, maybe we can have this discussion at the end because this is a very important discussion, and this also is
Yeah.
a bias of whom we are seeing age-wise. Dr. Kardolkar, this is a
Yeah, I'm back.
discussion we can have this later. Can we?
Yeah, I'm
Yeah.
back. I'm so sorry.
No,
I
no.
think
Thank
today
you.
there is some problem with the connections. Yeah, right. So I was talking about this boy who started with CK elevation. We thought Duchenne, then he had exercise intolerance, and we thought it is some kind of a metabolic myopathy. Then he develops distal lower limb weakness. And then we start looking at distal myopathies of various types. Then he develops proximal lower limb weakness. Then he develops upper limb weakness. So depending on at what stage I saw him, my differential diagnosis changed. Finally, this boy turned out to have a dysferlinopathy. So the point I want to make is that it's a time-dependent phenotype. So you see the person in one time frame. One can't derive too much, as is exemplified by this boy, where the differential diagnosis went through hypercikemia to Duchenne to metabolic to distal myopathy, and finally it turned out to be a distal myopathy. The sixth limitation is clinical signs are indicators and they're not sine qua non with molecular diagnosis. See, wherever I have traveled as an examiner, so often a DM neurology student will show a sign and then say, this sign is there, and therefore my molecular diagnosis is this. That's not the case. They're only indicators. So all these different signs that we have, the valley sign, the diamond on quadriceps, the biceps lump, the calf wasting, calf head on trophy, or what have you, they only tell you that it's likely to be this. They don't say it is this. The other thing that is happening is that now we're not doing a single gene. Recently, I listened to a very big doctor in movement disorders who was talking about deep phenotyping. And he said that deep phenotyping is so important that you can direct the geneticist as to what to do. Now, as we are going on, this point is becoming mute because we anyway do all the known genes, like our geneticists who work in the Advanced Molecular Diagnosis Center for Nerve and Muscle Disease. They are doing all the known genes for nerve and muscle disease for everybody. So in that sense, phenotype leading to a genotype, and therefore your correct inputs to the geneticist is becoming less relevant in some ways. It is very important to have phenotyping because when there is a mismatch, then you may be onto something that's more than what meets the eye and things like that. There may be more than one gene operating. There may be a difficult situation. So I'm not saying that phenotyping is losing its relevance. What I'm saying is the fact that a phenotype will lead you to do the correct genotypic assessment, that time is gone. So that's about the phenotype. Now let's see the genotype. What is a genotype? Again, Oxford Dictionary, the genetic constitution of an individual or an organism. And you saw what's the phenotype? The set of observable characteristics of an individual resulting from the interaction of the genotype with the environment. So the expression of the gene comes into picture. There is a bad gene, but how is it the faulty gene expressing? It manifests later. We don't know why it manifests later. We also don't know what are the factors which govern the expression. And we know of people who have bad genes and no disease. We know of people who have a bad gene, mild disease. We know of people who have fully expressed disease.
Yes.
So there are lots of unknown factors in the way the gene expresses. And this is an interesting picture which I've taken from a Nature Reviews paper. All these shells, oyster shells, are of the same genotype. But look at the difference in the phenotypes because their environments were different. So what's the limitation of the genotype approach? Limitation one is reverse of the limitation of phenotype. One genotype and many phenotypes. Example is dysferlinopathy. You have a distal myopathy, which is posterior leg, anterior leg, proximal myopathy, which is LGMD2, R2, then proximo-distal form, which we think is the commonest, polymyositis-like, exercise intolerance, hypercemia. So one genotype can result in so many different phenotypes. I think these slides will skip because this exemplifies one genotype, many phenotypes. The second example can be given is CMT. There are so many genes within the CMT that present as very different phenotypes. So like one gene, the M3Z, can have a dominant demyelinating neuropathy like CMT1B or a dominant axonal neuropathy, which is 2I or 2J, and also be the Dejerin-Shota phenotype. Or the NEFL can transmit as dominant, axonal, or a recessive demyelinating. That's absolutely mind-boggling. The dominant and recessive behavior of the genes changing in different families is unbelievably complicated, and it completely opens up a different problem. Like we recently saw a calpainopathy family, not recently, a while ago, a calpainopathy family where the transmission is dominant. Now, unless you have a good family study and genetic data of so many people, you may wrongly do the counseling. The second limitation is the problem of VUS, variants of unknown significance. We are all sort of from time to time facing this problem, that there is a VUS. It's VUS because it is not enough in the database and its significance is not clear. And you can do a little more work to try and predict its deleterious effect. And if you have facilities for more work, you can do the muscle RNA work to know what the VUS is. But VUS is a big problem. Some time ago, Dr. Hiral Halani did a publication on genetic appraisal of 106 myopathies from our region. And if you look at the spread, we had causative genes with 2 pathogenic variants in some. There were some very rare multigenic. And then there was a large chunk of 1 pathogenic variant and 1 VUS or both VUS. And really only about 40% of that 100 came in 2 pathogenic variant category. So those are the ones with diagnostic uncertainty, 1 pathogenic variant and 1 VUS or both VUS. And like I said, you must know what is common in your region. So in those patients, GNE, dysferlin, calpain were common. And GMPPV that Jarna showed you in the beginning was one of the uncommon ones. VUS in both alleles were seen in 25 out of 100 patients. And you really don't know at this point in time what to make out of those VUS. So those are the uncertainties of the genetic studies. Now, another example that would be given is of Pompe disease, where there was a patient with 2 VUS, homozygous VUS in Pompe gene. And this patient had a strong family history. His clinical features were suggestive. His biopsy showed vacuoles with glycogen granules. His alpha glucosidase enzyme was reduced. And therefore, we thought, along with the geneticist, that these VUS actually are pathogenic. And a representation was made. And these two VUS now are called pathogenic variants. So the phenotype and genotype, the clinician and the geneticist, have to continuously work together to move this VUS in relevant cases to likely pathogenic or pathogenic situations. Now, the limitation 3 is when you have an autosomal recessive disease and you have one pathogenic variant and the other VUS, things don't become certain. And therefore, you need more tests. Like in the GNE category, we had 29 cases in that paper where there was one pathogenic and one VUS. And then we had to rely on muscle biopsy again to know whether there are rim vacuoles and the segregation analysis in the family to know what is the significance. Then the intronic variants are difficult to diagnose. To say that, okay, we will get the gene, it's not always possible to get the intronic variants. There are problems with mosaicism and there are other phenomena. So I think these 3-4 slides I'll skip. The fourth limitation is the absolute unknown, where there are genes still to be discovered. Like you see families where you document autosomal recessive transmission, you get a nice phenotype, but you don't get the gene because there are genes still to be discovered. The pathomechanisms are still unclear. And the dominant and recessive behaviors of genes is another problem. So those are the limitations of the gene. Now, here is one patient with wasted calves and scapular winging. And we thought that this would turn out to be probably a calpain. But in fact, there was a problem with the dysferlin gene, homozygous pathogenic, and to add to it, anoctobin 5 gene, which is also heterozygous and pathogenic, and both produce a distal myopathy. Then there is multigenic inheritance, where more than one pathogenic genes you see in the same patient. And such patients are few, so you really don't know what these mean. Right. So, as we have elucidated with these examples, phenotypic approach has its limitations, genotypic approach has multiple limitations, and amalgamating the clinical and genetic approaches with the help from MRI scans or histology can help you to come to a composite diagnosis. And of course, molecular and biological research further is very necessary in so many conditions where you don't know. Now, one of the problems is that we are trained to do a certain thing well. Like the clinicians can do the phenotyping well. The geneticist does the genotyping well. And this is the classic fishbowl experiment, that if I'm looking at it from the side where I'm looking, it would seem as if the fish is going from right to the left. But somebody sitting in front of me will feel that the fish is moving from left to the right. What's actually happening is our point of view is very narrow. And if your point of view is correct, then you know that the fish is moving in only one direction, but we saw it in two different directions. So while we discuss the phenotype, we discuss the genotype, we know that there are so many unknowns between the phenotype and the genotype. The real issue, I mean, this is a bit philosophical, but the real issue is that till we come close to or get some inclination about who's the driver of this whole design, we probably will not know exactly what is happening. And today we consider gene as the last stop, but gene is not the last stop. And I'm sure another 10, 15, 20 years, we will know something more than the gene. The gene is a marker, a very consistent marker. Maybe it's a participating marker, but it's just a marker. It's a marker of something, the driver of which we at the moment don't know, which is the hard problem of the genotype-phenotype correlation. So as we have seen the two sides of the problem, the third limb is pathophysiology, which we have not discussed today, but that's another area where you find a hard problem. So where we stand today, I think this Einstein's statement is very apt. If you can't explain it simply, you don't understand it well enough. So we haven't understood it well enough, and in the coming time with further work on different things, in addition to phenotype and genotype, we may come a little closer to trying to understand this riddle. So thank you very much for your attention. Thanks, Anne, for arranging this. And I'm quite happy to take questions and comments.
Thank you so much, sir, for that elegant presentation. May I make just one, because you were talking and it got interrupted, may I just make one comment?
Yes, please.
As an answer to, no, let Dr. HVS go first. Please, sir. Dr.
I have
HVS.
a question to Satish.
Yes, sir. Please ask a simple one, sir.
Good. All you said was going over my head, sir, as a general neurologist. So I'm coming back to the general neurology question. The tremors which you said largely seen in neurogenic, but can also be seen in myogenic.
Yes.
Is it independent of the muscle weakness or is it related to muscle weakness?
Sir, independent of the muscle weakness.
Independent.
Independent.
So it can be seen in myogenic as well as neurogenic.
In very rare myogenic, and it seems that those myopathies which link with the sarcomeric protein problem seem to manifest tremors, but such patients are so few that even literature on them is not that much. This MYBPC1 case that I showed is also a sarcomeric myopathy.
The second question is, as a general neurologist, I will diagnose it as myogenic. Then after coming to a specialist like you, it may be turn out to be neurogenic. How does it matter to the patient in terms of management?
Yeah, a very good question, sir. Basically, I think when it comes down to prevention and counseling, we are getting more and more accurate. And therefore, the disease definition in terms of the genetic definition is becoming vital to try and prevent it from going into next generations, general counseling, and things like that. And I think making a diagnosis of a treatable disease, which is not that common in neuromuscular category, but they are there, that there is Pompe disease and similar diseases where actually a treatment may come. So I think it matters. It matters comparatively on fewer occasions for clinical neurologists. But I think it's essential for neuromuscular specialists if the field has to go on to primarily define clearly what they're dealing with.
Does it help the prognosis or only genetic advice?
Prognosis also, even though they are progressive conditions, all of them, some progress faster, some progress slower. So you are on a stronger wicket when you know exactly what is happening.
But suppose the patient is beyond the stage of reproduction.
Yeah.
So genetic also does not matter.
Yeah. Actually, sir, in clinical practice, when there is a family or a patient sitting in front of you, it's a completely interactive discussion as to what they want from the consultation, as to what can we offer from what science can tell them. It's a very individualized decision, changing with every family that you see. Yeah.
Thank you. Thanks a lot.
Thanks, sir.
Sir, may I add one comment to it from two
Yes, please.
doyens in adult practice to somebody from pediatric practice? Many times we tend to do genetics more because we are just basically the largest chunk of patients we see is all going to be inherited disorders versus the acquired ones. Even beyond reproduction, that's done by the fetal medicine people and the genetic counseling people. We do it because we feel we are more empowered to be able to tell them what to look forward to and how we can improve quality of life from a planning perspective. And so I guess, sir, it would be, if somebody comes to me, there will be a bias that somebody like me would always tell them, please do genetics. And there might be a bias because I'm very comfortable with the genetics and the VUS and all of those things. and that we can reverse phenotype sometimes and even say, okay, rewrite it or something like that. I'm not saying there's right or wrong. I'm just saying there's different POVs, like your last slide
Yeah.
mentioned,
Yeah.
because we come from different ends of the spectrum. And from the same thing, and this point was very good about your the tremors that you said. Sometimes in children, I remember one of my professors telling me that the tongue fasciculation was the cry of a dying anterior horn cell. But we know so many SMA patients we have whom most of the times they don't have an anterior, they don't have tongue fasciculation. We have more than 600 patients on follow-up. We use it to teach students to say, look, no tongue fasciculation. It is there intermittently on and off. It might be there. If its absence does not mean it is not there. And for that reason, I'm just adding to what Dr. Vaibhav said. So if they're coming to somebody like you, Dr. HVS, you understand. You were one of the first tertiary people in the state. That a patient reaching a tertiary physician is not rare, is quite rare. It takes a long journey for them to reach. Bigger cities, maybe. But what we are also telling for a younger population, what we are trying to tell them is the number of people who can do effective EMGs in very small infants is small. Somebody to reach either Dr. Kushnuma or Dr. Radhika is small. And so I tell Dr. Radhika openly, and when we teach peripheral doctors, if you have an infant who's floppy, and who's cognitively fine, we say, do not send to neurology, just do MLPA for SMN gene. This is what we're telling because it's a treatable disease. So I'm not telling it for everybody. We're only telling it for infants because its incidence is 1 in 6,000 and it's much more common. Sorry, Dr. Vaibhav, that is what I meant. We are basically making them a little less clever with regards to localization, but we're saying even before sending to neurology, do this because it's treatable and it is cheaper than doing the EMG. Sorry, that was my 2 pence from the pediatric world.
And a clarification, you said and the fasciculation is the cry of the anterior horn cell dying.
Yeah.
That statement is wrong now?
No, it's not wrong. It's true. But it's not dying all the time. That's the thing. It's like, like Sir mentioned, which point in the trajectory of natural history you are catching them. You
At
might
what
be looking at
stage?
that tongue when it is not dying.
At what stage?
Yeah, yeah.
Madam, don't you think the fasciculation overall is rare in SMS? It is less
Yeah.
common in SMS, as we see in the classic anterior disease.
Yes,
It
yes.
is more common.
Yeah,
S-
that is true.
It's a much slower process. Yeah.
SMS don't show fasciculation that
Yes.
prominently.
Yes.
Yeah, not
Maybe
as
few
common.
here and there, it's fine, but
Correct.
it's an
Correct.
unusual feature. Trying to say is that in differentiating SMA from myopathy in the early stages, no. So because in the EMG of SMS and
I think we lost Weber.
You're not audible.
I was audible or not?
Now you're audible. Yeah.
You're audible
Yeah,
now.
what I was trying to say was for differentiating SMA from myopathy, you don't need a relaxed muscle. That's the beauty. So even if it's a crying child, it's a throwing child, you just put a single needle and something you will get. And in SMA, whatever cases I have seen, as soon as you
Absolutely,
put in the needle, you get a prominent like neurogenic potentials.
sir.
So in one
I'm
of the
not
cases,
arguing with you on that.
yeah,
But the thing
agreed.
is, there are very few people like you. There are very few people like Dr. Radhika. We are few and far
Yeah.
in between. So when
No,
talking to doctors in
that's
the
what I'm
periphery,
saying.
sure.
You don't need a very expert electrophysiologist for that. It's a basic differential. You will see very large amplitude with reduced recruitment there, then and there if it's SMA. That's what I'm trying to say. And second thing is because it is that clinical judgment you have to make that whether to send for MLPA or WES, that is the problem. That's where the problem lies. So it can be a helpful tool. We should not forget means EMG. Sometimes what happens in the mechanically we start doing the things. So if you are planning EMG, do it before genitals. That's what I'm saying. If you are planning it. That can be
Yeah.
one of the additional thing in the differentiating things. And fasciculation point you have put rightly so because fasciculation is not at all helpful. Those things are not helpful in SMS. Somehow even in the anteromuscular disorders, when we talk about the anteromuscular disease in adults and the genetic disorder SMA, they are different.
Yeah.
Their phenotypes are also different.
Dr.
There's a
Khan.
question.
And
There's a
one more
question
thing
in
I
the
want to say that yeah, and one last thing I want to say, early in the course, reflexes are a good tool for differentiating SMA from muscle disease, but early in the course, like very early, like first if the history is just of 1 or 2 years, reflexes can be present in the SMA. They may be lost in 3rd year or 4th year later onwards. So that one thing you have to remember. That's it.
There's
So
a question in the
And
chat
I would hope
box.
that.
question in the chat, sir.
And sir, one more thing.
Yeah, please go ahead, Prabhu.
Sir, how do you proceed when can you just give in 1 or 2 lines that VUS how to make how do you make to convert into the pathogenic variants like that that was I was listening that very
Yeah,
carefully.
this particular one, everything that you require in Pompe disease was there. The phenotype was there, the muscle biopsy findings were there, the enzyme reduction was there. Only that the genetics has shown 2 homozygous VUS. So there was a strong case here that these are not actually VUS. And as luck would have it, we went on then further to find 3 more families which were indirectly related to this family, who also had the same VUS.
Then,
I think this VUS is just a process.
so then that
Till
would,
enough
And then whom do you
data.
report?
isn't it? They would get reclassified, isn't it?
Yes, they would. This particular one, the geneticist made a pitch for reclassification, and it was agreed upon
So whom it is reported, sir, then? Where do we report this?
to the database.
Okay.
That's where the geneticist took it up.
We usually report it back to the genetic testing people, the lab, and they
Yes,
sometimes
they
they
take it up.
reclassify it on our recommendation because that's the only way they can legally do prenatal testing. They can't
Correct.
test otherwise.
Correct.
So there's a question for you in the chat box.
Yeah.
I think
Yeah, I
if
saw
anybody wants to
the muscle
on the role
MRI.
of muscle MRI.
Muscle MRI.
What is your practice, sir?
Yeah, the muscle MRI, I think the MRI is gaining ground in neuromuscular diseases. And a lot of conditions now, MRI patterns are being recognized. And people are getting confident to say, based on the MRI, that look, this is likely to be this disease. And there are some very specific signs like the sandwich sign or a few other signs where you know that this is this disease. In fact, myofibrillary myopathies have been divided according to MRI patterns correlating with the genetics. So MRI is becoming an important tool. Now, MRI is an expensive tool. So again, whether we are going to use it, when are we going to use it, we will have to decide in a given case. But MRI is definitely coming up as a modality which is being used more and more. Also,
So what is your practice, sir? What is your practice?
Well, I primarily don't go for the MRI for the diagnosis because I still feel that the genetic diagnosis is more reliable at this point in time. Even if my MRI person says that this is very likely to be this, I still would like a genetic confirmation. So I'm first doing a genetic confirmation. But
So
sorry,
which part MRI do you order, sir? Arm, forearm,
well,
thigh, or
generally,
leg?
yeah, there are protocols set up. We at the moment do not have a protocol. We go case wise, depending
may I-
on which muscle we want to see. But there are set protocols now for MRIs of the whole body, which sequences and where to take. And there's a whole lot of literature on it already.
Sir, may I add to this?
Please, please.
So I tend to report our muscle MRIs, and we regularly do it, but we don't do it as often as we used to do it, say in UK, mainly because of the same constraint for cost constraints. But
Correct.
we do it when we get a VUS.
Yeah.
And that's a like using a muscle biopsy. It's a confirmation saying, yeah, this is this.
Right. Correct.
And we
Correct.
usually have a protocol which we've made it for ourselves. Ideally, we would like the whole body, but that's expensive. So we've gotten our institute to agree, saying that axial cuts, T1 and T2, not thin cuts of the leg and thigh together, they would use it as one sequence and they would do it for us. So for certain conditions like Pompe, they say the pathognomonic tongue sign and things like that, but that we don't go looking for it. But sometimes we've had even though it is said to be pathognomonic, even dysferlin can then do it.
Correct.
So we usually come up with a differential, and we have named a neuromuscular protocol in our institute, and we use it that way.
Fantastic.
You leg and thigh. You do leg and thigh, madam.
I do leg and thigh. I must say, so if anyone's interested, there's something called as Academio. Every year annually they do like 4 or 5 years of updates only on neuromuscular MRI. And they're so confusing. And they just make you feel really stupid because there's so many protocols. It's now the new biomarker. It's a biomarker for research tools. If they're giving interventions, previously they were looking at muscle biopsy to see how did you improve expression of protein. Now they're using muscle MRI as a tool to say, how did it improve the outcome? Not just
Correct.
functional outcomes.
Correct.
But
Another-
madam, only T1, T2 is not enough. No, stir will be needed, right?
Yeah, stir is needed. Yeah.
Stir is, so we don't use stir so much. You all use more in adult practice because you're looking at acquired.
Yeah.
I mean, acquired kind of stuff. We don't see so much dermatomyositis and all of that. They go to the rheumatologist.
But
So this is
even the
just
LGMD stir will be needed, no?
So the genetic
Because
ones
fat
I don't,
patients.
sir. I'm using only the T1 and T2.
Okay.
You know, one other slightly different point I wanted to make is that in a given department or a given unit, it depends on what is the constellation of that department as to what you are going to be using more. Like Kushnuma doing electrophysiology in our department, if we send a myotonia to her, she can tell us practically the genotype. Now, that's phenomenal. But it depends on what sort of expertise you have in a given department about histopathology, about genetics. And then you will try and synchronize and synthesize your own protocol for which works best for the patient and for you. So it's so much dependent on the place you're working, the people who form the group, the facilities that are available. I think it's all, and the type of patients who come to you. So it's all a mixture. There's no real set protocol. Like Dr. HVS was saying, why is it important? It completely depends on what is the question being asked to me. If the family is asking a particular question, the answer for which is in genetics, it will be genetics that I'll ask for. If it's only rehabilitation, it will be only rehabilitation. So it's such a dynamic thing and so much case-based, so much department-based, so much expertise-based that no two are the same. Yeah.
So that was a fantastic session. It started on time, it's ending on time. This is really amazing and very lively answers. So Dr. Rajesh is just commented, sir, thanks for a very informative talk. And he's asked, what is your experience and approach to LGMD, which may have some overlap with inflammatory myopathies at presentation as management decisions would be different. He's a pediatric neurologist based in UK.
Right, lovely. Rajesh, thanks for the question. You know, the inflammatory component of the genetic myopathy, except for the Duchenne muscular dystrophy, at this point in time, there isn't much literature to support the fact that immunosuppression should be given. There are trials going on in limb-girdle muscular dystrophies and some other dystrophies. But if you generally look at which sort of limb-girdle dystrophies we see inflammatory cells in adult practice, we see them regularly with dysferlinopathy. We see them with calpainopathies. And besides these two, you see inflammatory cells in some others, but not all the time. In fact, you give steroids to a patient with dysferlinopathy and the patient can worsen tremendously. So at this point in time, except for Duchenne, immunotherapy for other inflammatory-like genetic myopathies has not been standardized. So we don't use it as a regular thing beside Duchenne. But a good study is required to know whether it helps or not. What is that inflammation doing is something that we don't know yet. It's a genetic inflammation, if you like. Yeah.
Sir, may I ask you a doubt on that?
Yes, of course.
So Duchenne is standardized with regards to how much dosage. We know what long-term steroids do, and we titrate the dose to offset the side effects. But we were taught as well that and experienced and we had some experience with dealing with any muscular dystrophy where a carbohydrate moiety was involved, like an alpha dystroglycan or alpha dystroglycanopathy or something like that, and sometimes the sarcoglycanopathies, that we could give them steroids, but not the same regimen as the Duchenne. would be a much lower regimen, and we'd
Mhm.
have to say end point of when you're starting and end point titrating. Is that very wrong?
No, no. Only that we do not have a standardized standard of care that has
Yeah,
emerged
yeah.
yet, which may.
Yeah.
See, earlier on,
Yeah.
when we did not have all the facilities, for some 2 or 3 Duchenne phenotypes, I have given steroids only to realize later that they were sarcoglycanopathy. And even those children showed some benefit. This is absolutely anecdotal, but we don't know what dose and what sort
So
should we be doing. On the other hand, for dysferlin, it can worsen.
that
There
is
are
known.
patients who
Well described.
really
Yeah.
become, suddenly they go down. And occasionally in Calpain also, they say, I'm not feeling well, and they go down a little bit.
So we don't give it for calpain, but sarcoglycan, I think we have around at least over 10 children that we have given long-term steroids. When I mean long-term, it will be probably 2 or 3 years. But we are
And
very
what is the
cautiously giving.
experience? Well,
They are doing reasonably okay.
yeah, the
disease is slow.
inadvertently,
giving
that's what
1/3
I've
the dose.
seen.
Yeah, 1/3 the dose of what I'm giving in DMD
Okay,
is what we are
right.
generally giving.
That's
Anywhere
interesting.
between 1/3 to half.
Yeah, there's still a lot there in terms of understanding of the pathophysiology. I mean, why are the cells there? What are they doing? Yeah, see, if you take a corollary of CMT, there are patients of CMT in whom biopsies were done and you found cells, and all of them were not deteriorating. And because people saw cells, they gave steroids and all of them didn't improve. So there is this business of inflammatory component to a genetic process. Whether we can remedy it by using something, our current example is only Duchenne.
You mentioned CMT, sir. CMT, there have been mentioned the CMT plus CID per inflammatory variants also.
Yeah, those are the people
Yeah.
who are deteriorating clinically rapidly.
Yes.
And their electrophysiology is showing an acquired pattern of demyelination. Like we've seen one patient today itself, that this patient has pes cavus. His son has a pes cavus. They have a CMT2-like phenotype. But this one is deteriorated so rapidly that we ended up giving him IVIG. After giving IVIG, his lower limbs became better, but his upper limbs became worse. So we now
Same, I also had
contemplating
one case,
what
he didn't
further to
improve
do.
much with IVIG and steroid also. Didn't improve much.
Yeah. So I think inflammation is a pathway, and genetic cascade as another pathway. Obviously, they meet somewhere, but we haven't deciphered them well enough in most conditions to know what to do about that. In fact, it may be incorrect to classify them separately, and in time to come, we may actually see them as the same process with 2 limbs, inflammation at one end and the other cascade at the other end. But that's just a thought. Great. So we've had a very nice session today.
Thank you so much for the very lively discussions and good thoughts.
I enjoyed it. Thanks very much for arranging this program.
Thank you. Thank you to
Grateful.
ORDI and you and to your team. Thank you so much to Dr. Jarna for setting the tone.
Thank you, ma'am.
Yeah.
Thank you so
She-
much for the opportunity.
And
she's
thank
a
you, Dr.
future
Vaibhav
star.
and Dr. Rajesh and HVS
Thank
sir.
you, ma'am. Thank you. Thank you so much.
Okay, good
Thank you,
night.
sir. Thank you. Good night, everybody.
Take care.
Bye.
Take care. Bye.
Bye.